Worldwide, each year, 1.4 million children are born with congenital heart defects, and over 350,000 children acquire heart disease. You are taking care of them. The vision of the World University for Pediatric and Congenital Heart Surgery is that every healthcare professional, anywhere in the world, involved in the care of patients with pediatric and congenital heart disease should have access to ongoing education. Education, communication, mentoring, knowledge everywhere and for all. Imagine being part of it.
Hello, my name is David Overman, and it is my great pleasure, along with my co-chairs, Drs. Yishai Orr and Kisaburo Sakamoto from Sydney, Australia, and Shizuoka, Japan, respectively, to welcome you to the World University for Pediatric and Congenital Heart Surgery's 11th educational webinar. Following up on our 10th webinar, Atrioventricular Septal Defect, the Basics, today's webinar is Atrioventricular Septal Defect, Complex Types and Issues. During our 2.5-hour session today, we are honored to have world expert international faculty members who will discuss important topics related to the management and surgery for atrioventricular septal defect. Please take a moment to note there are no conflict disclosures for this webinar. Each presentation will be approximately 8 minutes, with 6 minutes reserved for questions from the audience. In order to maximize everyone's learning enjoyment of the educational material, the audience computer microphones will be muted. We encourage you, however, to ask questions using your chat function on Zoom. To submit a question, open the chat function, select the moderator's name, Dr. Orr, type in your question, and press the Enter key on your keyboard. Also, please note that the program is recorded and will be available on the World University website within a couple of weeks. Dr. Sakamoto will be introducing our speakers today, and Dr. Orr will moderate the question and answers after each talk. Okay, so let's get started with our program.
Okay.
Oro?
Thank you very much, David. So I would like to start the lecture session. So first, lecturer is Professor Vera Aiello from São Paulo, Brazil. The lecture title is Atrioventricular Septal Defects, Morphology of Complex Types, including Conotruncal Anomalies. Vera, could you please start your lecture?
Hello, my name is Vera Aiello. I'm a pathologist from the Heart Institute of São Paulo in Brazil, and I have to thank very much the organizers for this very kind invitation to participate in this webinar. I have no disclosures. The first question to be answered is, what is complexity in atrioventricular septal defects? I may confess I don't have the answer to this, but I thought that I should discuss with you cases with morphological features that interfere in the indication of the correction, surgical correction, primary versus stage repair, unit versus biventricular approach, for example. Also, any morphological feature deviating from the commonest forms of AVSDs, and also features bringing additional challenges to the surgical correction, like obstructive lesions and so on. So I decided to discuss with you the extent of the sharing of the common AV junction between the atrial and ventricular chambers, the unbalanced forms, the extremely dysplastic and deficient valvular leaflets and with deficient tissue, the left ventricular tract obstructive lesions, the lesions associated of the ventricular arterial connections, or the Conotruncal anomalies, as you may call them, rare forms of AVSDs with isolated ventricular septal defect component, and also double orifice of the left AV valvular component. The first slide here shows the unbalanced forms. On the left-sided panel, we see the short axis section with the dominant right ventricle compared to a very small left ventricle. You see the common junction with the two bridging leaflets, the inferior one and the superior one. In the right-sided panel, we see a dilated left ventricle, a very big one compared to the right-sided ventricle, and with the left-sided the cleft and to the two bridging leaflets, and additional hypertrabeculation of the myocardium of this left ventricle. There are other features that we should pay attention to in unbalanced ventricle. Sometimes there is alignment, complete alignment between the septal structures, the remnant of the atrial septum and the ventricular septum here. In this heart with mirror image arrangement of the atrial appendage or situs inverse, like you may refer to. You see here the dominant right ventricle and the small left ventricle with aligned structures. But you may also find, like in this right-sided panel, grossly malaligned septums, like the ventricular septum here in the red dotted line and the atrial septum in yellow dotted line, causing a situation that is usually called double outlet atrium, like here the right atrium empties both in the right morphologically right ventricle and in the morphologically left ventricle. There are very good indexes in echocardiography that may be used to judge if there are imbalanced ventricles, like the size of the components, the right and left atrioventricular valve components, referring or correlating to the size of the ventricles. Other index is the angle between the top of the ventricular septum and the point of the AV junction, for example. But we know from the morphological point of view that not always the size of the diameter of the valvular components correlates perfectly with the volume of the ventricles. Look at this left-sided four-chamber section. You see a common junction, and the right component very big, left component small, and this right-sided component correlates to a very good sized right ventricle. But look now to this left-sided panel. You see the right component is bigger compared to the small left component, but we can also appreciate that there is obliteration of the trabecular portion of the right ventricle. So the big diameter does not correlate to with the size of the right ventricle. So not always the valvular diameter correlates with the ventricular volume. We should also discuss the dysplastic leaflets of the common AV valve. In the left panel here, we see the primal defect. We are looking from the left side of the heart. You see here the superior bridging leaflet, very thick, with nodules and also excrescences that would impair the surgical results. So this is called the dysplastic components or dysplastic leaflets. Look also to this four-chamber section in a heart with isomerism of the atrial appendages. You see here the remnant of the atrial septum, and the left component of the common AV valve is very thick. It impairs the filling, the adequate filling of the left ventricular cavity that indeed is very small compared to the right ventricle. In this other case, seen from above, we see the common AV junction. We see here the bare ventricular septum, the surface of ventricular septum, and the inferior bridging leaflet that is divided. Here you see the division of the inferior bridging leaflet. The superior bridging leaflet is not very extensive, but even if there is sufficient tissue to be repaired here by the surgeon, you can appreciate that the mural leaflet in this case is very tiny and may compromise the result of the surgical correction, not only because of the bridging leaflets, but also the size of the mural leaflet may interfere in the surgical success. Another example of a deficient valvular tissue is observed here. We see the left ventricle opened. The inferior bridging leaflet is very dysplastic and small. From the annulus to the edge, it's very short. And instead of a connecting tongue, there is a big tissue tag that may or may not be incorporated in the surgical repair. So associated with this dysplastic valve, this deficient tissue may also impair the surgical results. The left ventricular outflow tract obstructions may appear in the presence, in the context of concordant or discordant ventricular arterial connections. So may appear in AVSDs with transposition or normally related great arteries. In the surgical series, the prevalence is around 4%, and there are several causes. One of them is the presence of tissue tags from the superior bridging leaflet, like we see in this panel here. We see the ventricular surface of the superior bridging leaflet that has attached a big tissue tag that interposes below the aortic valve, causing subaortic stenosis. We may also find anomalous chordal attachments from the superior bridging leaflet, fibromuscular membranes like the one published by Tlaskau and co-workers in 2014, and also septal hypertrophy. All these are causes of left ventricular outflow tract obstruction in AVSDs. The associated anomalies of the ventricular arterial connections are the following. Barati and co-workers published a large anatomical series, more than 500 cases, and found out that 6% of them had tetralogy of Fallot associated with atrioventricular septal defects, 7% that had double left right ventricle, and 3.5% had transposition of the great arteries. A very big surgical series comes from Melbourne in Australia and was published in 2020. There were 38 cases, 95% of them with unbalanced ventricle. This is very interesting finding, with the dominant right ventricle in more than half the cases. Bautista Hernandez and co-workers also published a series of transposition associated with AVSD. 3 of their 4 cases had left ventricular outflow tract obstruction, and 2 of the 4 cases had multiple VSDs. In these 2 panels show tetralogy of Paulo associated with AVSD. We can appreciate very easily that the VSD extends from the inlet to the outlet with anterior deviation of the outlet septum that causes subpulmonary obstruction. Here you also see the very big extension of the VSD that comes to become, goes to become subaortic in position. And here also the outflow, the outlet septum is deviated to produce a very severe subpulmonary stenosis. It's very interesting to notice that more than 90% of such cases of tetralogy associated with AVSD have a free-floating superior bridging lift, like in this appear in these 2 examples here. So it's a Rastelli type C type. Here is another example of associated anomaly of the ventricular connection. Is a case of transposition of the great artery with pulmonary stenosis. Here we see the anterior aorta arising from the morphologically right ventricle with a superior bridging leaflet, not free floating, but firmly attached to anomalous papillary muscle. So it's Rastelli type B. Other cases of associated anomalies of the ventricular connections are exemplified here. On the left panel is pulmonary atresia and aorta from right ventricle. You see here the superior bridging leaflet in fibrous continuity with the aorta from the right ventricle. And this right sided panel, we have a very rare case of a common arterial trunk associated with atrioventricular septal defects. Also, the VSD extends to the outlet to become subtruncal, and there is fibrous continuity between the superior bridging leaflets and the truncal valve. I would like to discuss with you now the rare forms of AVSDs with isolated ventricular septal defect components. See from the right side of the heart, right atrium, right ventricle, that there is no atrioseptal defect, and the superior bridging leaflet continues to the left through this inlet VSD. When we observe the same heart from the left side, the left ventricle here, the left atrium here, we appreciate that the bridging leaflets are attached to the underneath of the atrioseptum. We see here the cleft of the left-sided component of the common valve. The surgeons at the Heart Institute usually teach us that in order to correct and to inspect and to explore the right side component, it's mandatory to do a surgical septectomy since there is no atrioseptal defect. So they usually section the atrioseptum to correct the left-sided valve. Well, last but not least, I would like to show you an associated lesion that may impair the results of the surgical correction. Here, the common junction, a complete form, a superior bridging leaflet, inferior bridging leaflet, and a second orifice, a very small one, second orifice of the left-sided component, guarded by cords. And here in the right-sided panel, there's already corrected AV septal defect with a single patch that shows in the left-sided component a very large second orifice. This may or may not cause postoperative valvular insufficiency. So in summary, complexity, morphological complexity in AVSDs are related to the broad morphological spectrum of this anomaly. Particular features, like we discussed, may challenge the surgical approach. and associated anomalies may require concomitant repair like transposition or tetralogy of Fallot. And valvular dysplasia or tissue deficiency may bring serious threats to valvular competence in the postoperative period. I thank you very much for your attention.
Thank you very much, Professor Aiello. That was a great insight into the extraordinary complexity of AVSDs. We have time for one question, and it's actually quite a challenging question posed by Adrian Cusian. So how do we diagnose on specimens double inlet left or double inlet right ventricle via a common atrioventricular valve versus an unbalanced AVSD with right or left ventricular dominance?
Thank you very much, Dr. Orr, for the question, and for Adrian also. Hi, Adrian, how are you doing? This is a very challenging question. Well, I usually say that when there is malalignment between the atrial and ventricular septums, so we can say that there is double inlet, but when we cannot say or there is alignment, I would say that it's just unbalanced form. I don't know if it's clear, Adrian, or not, but this is the way I see this problem.
Just in this, thank you very much for that answer. Just in the interest of time, we might keep moving on to our next presenter, and we might come back with some questions over the next
Okay, thank you.
Thank you.
Now, so we would like to invite the second lecturer, Professor Satoshi Yasukochi from Nagano, Japan. The lecture title is Imaging for Complex AVSD, Echo, Low Lobe 3D Echo, MRI, Catheterization. Could you please start your lecture, Satoshi?
Thank you very much for inviting me to World University for Pediatrics and Congenital Heart Surgery. It's my great pleasure and honor to be in part of this seminar today. My name is Satoshi Yasukochi from Aiello Hospital in Nagano in Japan. Today's my topic is imaging for complex AVSD. I have no disclosure. Complex AVSD is AVSD beside the AVSD. There's many associated anomalies such as unbalanced ventricles and other complex congenital heart disease. How imaging can do for complex AVSD? The role of the imaging in the complex AVSD is provided the following assessment and information to make a decision how to treat and manage the patient in the light of morphology and hemodynamics in the functions. Morphology is of course anatomy is intracardiac and extracardiac structures and valve complexes and size of the chambers and valves and vessels. Flow dynamics such as shunt, stenosis, and regurgitation is very important, and also non-invasive pressure estimations of pulmonary arterial hypertension is very important too as well. And chamber kinetics and myocardial wall kinetics is very important to assess. And flow kinetics for pre-roll and after-roll contractility need to be assessed for further making a decision for the treatment. Echo is good at real-time assessment, especially for the intracardiac anatomy in valve morphology. And MRI has a golden standard for the volumes and also quantification of the flow. CT has a precise 3D reconstructions, bring us 3D reprinting and modeling. CAS can be done for the 3D rotational angio with a more precise diagnosed during the catheterizations. Imaging for the chambers. This is the case for unbalanced ventricle and complex AVSD. Left panel shows a small RV, right panel shows a small LV. How to determine the unbalance in the ventricles? This is for the reported for the Yagas-Warren in AV valve indexes, which is left AV valve area divided by total AV valve area. They reported for the more than 0.6 is a left dominant, and less than 0.4 is a right dominant. And they also reported less than 0.19 go to like a univentricular repair, and rather than biventricular repair. Since then, there are many people who has proposed indices for the unbalanced ventricles and prediction for the successful biventricular repair, such as RV-AV inflow angles, and index in the ventricular septal defect, and index in the secondary annulus. Ventricular volumes by MRI is a golden standard and the quantification for the AV-RV volumes. Recent days, the 3D echo also can assess for the ventricular volumes even in LV and RV. We can also combine for all each chambers and volumetry and also the functions, and put together the quad imaging to give us how each ventricular chambers or each atrial chambers can contract and interact, and also affect each other. Volumetry of the unbalanced ventricles, eyeball is still important, but more quantitative measure is necessary. MRI volumetry is a golden standard. 3D echo may take place of the MRI. Imaging for common AV valve is also important. This is the case for the unbalanced AVSD in the parachute mitral valves with a single papillary muscles. The 2D echo gives us tip of the valve, common AV valve in morphology very well. 3D echo has a more benefit than the 2D echo. We can see not only for the tip of the common AV valve, but also like an infravalvular structure such as the caudate and papillary muscle attachment. 3D echo also has a more privileged advantage to see how common AV valve morphology and also regurgitation mechanisms. Visualization of the common AV valve is more important, and the 3D echo in the 4D assessment it become more important. Imaging for the extracardiac region is also important for the complex AVSD, especially for the CT in a reconstruction is good for good to see in the morphology and the 3D spatial relations of the great vessels in the airway. Imaging for the flow, especially the quantification for the flow, is very also important. MRI has a golden standard quantification of the flow using phase contrast assessment. We can measure for the output and also the QPQS ratio, and sometimes we can make a regurgitation diffraction of each valve. Recent days, echo can do the same thing in MRI in flow measurement quantifications. This is the vector flow mapping. We can convert it from the color Doppler to stream to get the streamline display in intraventricular the flow dynamics. By using this vector flow mapping, we can quantify for regurgitant fractions, and we can cross the line whatever you want and measure for any flow volume across a set line, and to give us forward flow and regurgitant backward flow in a ratio. So which means in a regurgitant fraction, this case in 14% regurgitant fractions. Imaging for dysynchrony in complex AVSD is also very important. This is a case for the S-plane and complete AVSD in the DORV in pulmonary atresia. The case was developed in interventricular dysynchrony, which was shown in simultaneous angiography in LV and RV in this slides. For this case, we use what a 2D speckle tracking and guide to set the optimal pacing site for the cardiac resynchronization therapy. So before CRT is after CRT, the RV and LV in a contraction is more simultaneously. This is another case for the imaging for the dysynchrony in a complete AVSD and the DORV PA. Using the 2D speckle tracking, the middle panel shows that before CRT, is RV-LV was contracting in opposite directions, but after the CRT, RV-LV was contraction at the same direction, and also the point of the peak of the contraction was at the simultaneously. Multimodality imaging is an essential key for strategic planning and assessment to manage the case with the complex AVSD. The role of the 3D echo becomes more important in surgical planning, assessment of the outcome and complications. The modern imaging technology enables us to understand the fundamentals of mechanism when and how to treat a patient with complex AVSD. This is the final slides of mine. Japanese mountain monkey can use for the iPhone in hot spring. So in this sense, why don't we make the most of the current advanced imaging tools for this in a complex AVSD? Thank you very much for your attention.
Thank you very much, Professor Yasukochi. That was an excellent talk and covered some really interesting topics. I thought that there hasn't been any questions on the chat as yet, but I thought the use of speckle tracking echo to look at ventricular synchrony is really interesting, because we've had some very challenging single ventricle patients where we've questioned whether resynchronization therapy with the two ventricles would work. So that's a very useful tool to know that it exists. Do you have a rough optimal age and size where cardiac MRI is most useful for assessing ventricular volumes and balance as a tool to decide the repair strategy?
Yeah, I think that MRI has still the gold standard to measure for the volumes quantitatively. But I think in the recent days, the 3D echo may take place in the MRI position. I think it's the advance in the technology for the 3D echo give us a more precise volume measurement. And also we can just combine for the volume measurement with two chambers, like in the atriums and ventricles, in the right side and the left side and the ventricles. So we can just to see how both ventricles interact with each other. I think it's a very important issue for the ventricular septum kinetics itself. I think it's maybe near to come. I think it's we need to consider for how the ventricular septum is act before and after the surgery.
Yeah, definitely.
To give us a more good eye.
I think it's something that's often overlooked a little bit. So I've got a question from David Overman. What's your view of the role 40 flow vortices assessment in AVSD and other lesions?
Well, I think this is a good question. I think we can see in a vortex in interventricular dynamic flow. I think it's after you're repairing for the atrioventricular septums. As a recent paper shows, in a normal in heart, it's a ventricular flow just into the center of the left ventricle. But I think it's if you had surgery, so after the surgery, I think it's the ventricular flow toward to the lateral side instead of the left center side. I think it's maybe the flow was in the direction was different. So that may gives you like in a ventricular mechanics kinetics as besides the flow interflow dynamics as well. So I think it's very important to see how ventricular streamlines goes, and also where the vortex was formations, and also how big and how vortex can affect valve closure and opening, and also like the ventricular contraction as well.
Excellent. Thank you very much. It's fascinating to see how much imaging has evolved over the last few years and how much useful information it can provide to us as surgeons. So I think we might move ahead with the next talk. We might potentially come back for some later questions as the chat heats up a bit.
Yeah. Don't forget the Japanese mountain monkeys too.
Absolutely. Thank you very much.
Okay, thank you very much for Satoshi. So we have to move as the third lecturer. So third lecturer is Christo Tchervenkov, as you know where, and from Montreal, Canada. And the lecture title is AVSD with Conotruncal Anomalies, TOF, DORV, TGA, and Truncus. Would you start your lecture, Christo?
Thank you, Sabu. Good morning, my friends from North and South America. Good afternoon, my friends from Africa and Europe, and good evening, my friends from Asia and Oceania. I have no disclosures. Atrioventricular septal defects with conotruncal anomalies are uncommon. This is a fascinating combination of malformations, extremely challenging in terms of surgical approach. I'm trying to advance my slide. So the goals of surgical therapy or surgical correction, obviously, our first choice to achieve an anatomic biventricular repair, to close the septal defects, ventricular septal defects and atrial septal defects. That's a bit of a misnomer in double outlet right ventricles, since we're not really closing the VSD, but we are creating an intraventricular pathway separating the left ventricular blood from the right ventricular blood, achieving an unobstructed pathway from the left ventricle to the aorta, unobstructed pathway from the right ventricle to the pulmonary arteries. We need to achieve as competent atrioventricular valves as possible. And obviously we need competent semilunar valves. So that's a formidable surgical challenge. A lot of the information that we have on these malformations comes from this really classic paper and classic study by Barati, Kirkland, McAllister, and Morris Lev. This was a study of 507 hearts with atrioventricular septal defect at the Chicago collection, as well as the Armed Forces Institute of Pathology in Washington, which established some of the incidences of these conotruncal anomalies. So there were 30 patients in this 507, almost 6% that had tetralogy of Fallot. Because this topic was expertly covered in a very nice way by Mark Redmond from Dublin, Ireland, at the second tetralogy webinar on December 12, 2020, I will not cover that topic again. I encourage those of you that would like to review the AVIS septal defect with tetralogy of Fallot to go to the World University website and consult that video in the World University Library. So focusing on AVIS septal defect with double outlet right ventricle, there were 34 cases for an incidence of 6.7% in that series. And just like double outlet right ventricle with a normal AV connection, the ventricular septal defect, by definition, in atrioventricular septal defect starts by being an inlet VSD. In about half of the patients, there was a subaortic extension, a little bit mimicking or much more exaggerated extension and anterior deviation as in tetralogy of Fallot. However, there were also rare types, 3 cases of doubly committed, 1 subpulmonary extension of the inlet VSD, but almost half of the patients had a VSD that was restricted and confined to the inlet only without any outlet extension. Now, in another series by Van Praag, they made the case that the majority of cases of atrioventricular septal defect and double outlet right ventricle transposition are really unbalanced. So it's a rare cases that could be candidate for biventricular anatomic repair. So if we have a subaortic extension, in the case of a double outlet right ventricle, the repair is achieved by two-patch technique, and the patch for the subaortic area has to be comma-shaped, very exaggerated, and the greater the override of the aorta over the right ventricle, like in tetralogy, the wider and the more voluminous that patch has to be in order to prevent subaortic obstruction. However, if you have inlet VSD extended to the subpulmonary area, as this case that was published by Roger Mee, subpulmonary extension of VSD, you can achieve anatomic biventricular repair by closing the ventricular septal defect with a comma-shaped patch into the pulmonary artery, followed by the arterial switch operation, which was done in this patient. What do we do when the VSD is restricted to the inlet without any outlet extension? Well, these patients were previously treated with a single ventricle pathway, eventually the Fontan operation. Al Pacifico in the 80s published on several cases where there was closure of the main pulmonary artery, atrial switch, and left ventricle to pulmonary artery conduit. We have used the technique of VSD translocation to repair these patients and to achieve a biventricular repair anatomical with the left ventricle connected to the aorta. This is an illustrative case we treated in 1989, a patient with Rastelli type C AV septal defect, double outlet right ventricle with non-committed VSD with no outlet extension. Therefore, both great vessels arose 200% from the right ventricle. So complete origin of the aorta from the right ventricle, pulmonary stenosis. This patient also happened to have coronary triatum, left SVC to unroofed coronary sinus. So after repair of the atrioventricular septal defect, we left a little corner in this area at the upper corner of the inlet VSD, and that guided us to create a new VSD, a very large new VSD in the subaortic area. This is not a simple enlargement of a restrictive subaortic VSD. This is really closing the inlet VSD and creating a new VSD in the subaortic area. And that's why I call this a VSD translocation. And then with the second Gore-Tex patch, an intraventricular tunnel now is created, tunneling the left ventricle to the ascending aorta. This is the patient 9 years after the surgery with absolutely no obstruction from the left ventricle to the aorta, and you can imagine the length of the pathway from the VSD that was created to the aorta, absolutely unobstructed. This patient of mine is now 32 years old and actually works at our hospital. There's a very large series published by the Ann Arbor group, Ed Bove, Jennifer Hirsch and colleagues, Richard Ricoyer, achieving biventricular repair in the AV septal defect with double outlet right ventricle. They had 16 patients, 12 had heterotaxy, 6 patients also had concomitant total anomalous pulmonary connection. They achieved primary repair in 6 patients, initial palliation in 10. They enlarged the VSD in 11 patients, used RV to PA conduit in 13 with to achieve a competent pulmonary valve. There was 1 early and 1 late death, no late left ventricular outflow tract obstruction, and the risk factors for mortality and significant morbidity of the patients with heterotaxy and total anomalous pulmonary connection. Absolutely outstanding results. And this is their surgical technique: repair of the atrioventricular septal defect, leaving a small area here unclosed, through which a subaortic VSD was created or achieved, and then a second patch completing the left ventricle to the aortic tunnel. Now focusing on transposition, even more rare association, only 3.4% of this in this series of 507 specimens at transposition. And another paper from 1963 by Bosen in 178 patient with transposition only 3 patients had atrioventricular septal defect. So very uncommon situation, and many of these patients have unbalanced atrioventricular septal defect and not candidates for biventricular repair. Now, if you have no left ventricular outflow tract obstruction, it's more straightforward. You repair the atrioventricular septal defect and perform the arterial switch operation. And there are several cases reported in the literature by Kumar in 92, Rafnin in 95, our co-host Kisaburo Sakamoto in 98, Katogi in 2000. What to do when this AV septal defect transposition left ventricular outflow tract obstruction? The easy way out would be to follow a Fontan pathway, or patients have been repaired by Pacifico, had 4 patients where he did the VSD closure, repair the AV septal defect associated with atrial switch operation, and in 1 patient had total anomalous pulmonary venous connection, had an atrial buffle. Again, I would like to submit for these cases, we can also use the technique of VSD translocation, which can be performed in this fashion after repair of just similar like the other case I presented. After closure, repair of the AV septal defect, a new ventricular septal defect is created in the subaortic area and followed by left ventricle to aortic tunnel and reconstruction of the pulmonary circulation. We had a patient, a 6-month-old, that had balanced AV septal defect transposition, all virtual atresia, but severe left ventricular outflow tract obstruction. There were 4 major aortopulmonary collateral arteries. This patient underwent a single-stage bilateral pulmonary artery unifocalization, VSD translocation, and anatomic biventricular repair. And this is again years later. You can see the left ventricular to aortic connection absolutely unobstructed. And in this AP view, you can see the length of the pathway from the left ventricle through the newly created VSD to the aorta unobstructed. AV septal defect with Truncus arteriosus is extremely rare. There have been some publications with 11 post-mortem cases in the literature. There are 2 cases reported of successful surgical correction, and a paper by Hio, Olivieri, Jonas, and Signa in 2015 in the World Journal. All these patients were subjected to single ventricle palliation. This is a very challenging situation when it's extremely rare. But the second thing, the truncal valve is can be abnormal in terms of function. There could be stenosis, there could be regurgitation. So in addition to not having a pulmonary valve and having AV septal defects where the repair may be suboptimal, you add also the fact that you have potentially a non-optimally functional aortic valve. So that's a huge challenge, but this is extremely rare and it's been rarely reported. So in conclusion, AV septal defect with conotruncal anomalies is an extremely complex and heterogeneous group of malformations, obviously presenting a formidable surgical challenge if one is to attempt an anatomic biventricular repair. Several surgical techniques exist to achieve anatomic biventricular repair when the AV septal defect is balanced, to achieve an unobstructed left ventricle to aorta pathway, right ventricle to pulmonary artery, and avoidance of significant 3-valve regurgitation. AV septal defect with complete origin of the aorta from the right ventricle is particularly challenging. However, the technique of VSD translocation that we've demonstrated allows anatomic 2-ventricle repair. However, these lesions are extremely heterogeneous and the surgical approach must be highly individualized. I thank you very much for the opportunity to present this information to you this morning. Thank you.
Thanks, Christo, for another fascinating talk. I think the topic of VSD translocation has obviously stimulated a lot of questions. Myself and some others would love to know how you predict where the conduction tissue is. And I know the overall rate of this being performed is very limited in terms of being reported, but do you know what the rate of heart block is for the procedure?
Excellent question. Obviously, the issue of the conduction pathway is extremely important. We know that in AV septal defect, the conduction system is at the lower end, it's inferior, because that's how it is pushed by the absence of inlet septum. You avoid the conduction system the way you repair every single AV septal defect without conotruncal anomalies. So that part of the operation is similar. I have done two techniques. One is to follow sort of the left-sided aspect and leave the coronary sinus on the appropriate side, on the right side. When I trained with Alto Castaneda, he often left the coronary sinus on the left side. So I don't think there's anything peculiar about the conduction system, whether you have conotruncal anomalies or not. Now, when you create the ventricular septal defect translocation, you're leaving a little opening at the superior end of the repair, and that will guide you through the then infundibulotomy incision to create the new subaortic VSD. And in that area, you're far away from the conduction system. Now, I guess you can always damage the first septal perforator and affect the septal perfusion, but I think that's my answer to that excellent question.
It's clearly an operation that takes a lot of fortitude to perform. The next question is, what's your threshold to enlarging or translocating the VSD in tetralogy with AVSD to avoid LVOTO when the aorta is demalposed?
Yeah, I had two excellent drawings. These drawings were done by my resident, Steve Corkula, about 20 years ago, fascinating, great artist. And I took out these slides on tetralogy because I wanted to avoid duplication of the two talks. But basically, when I trained with Aldo Castaneda, we used the single patch technique to repair AV canal with tetralogy by dividing the superior leaflet. And Aldo always made the point, you have to make the cut deviated onto the right side, basically to follow the anterior conal septal deviation. More recently, or actually quite early in my career, I didn't like the idea of cutting the superior leaflet. So I adopted a two-patch technique with a comma-shaped patch where I would anchor during my AV septal defect repair. I would do that part and then leave quite a redundancy of the patch superiorly. And then when I do the infundibulotomy incision, I would tailor the upper end of the patch to the appropriate size and continue the closure from above. I think it's to avoid the left ventricular flow tract obstruction. You just have to make sure that you patch, the head of the patch is of adequate size. And I guess every case is somewhat individualized.
Excellent. Thanks very much, Christo. In the interest of time, we might move on, but I'm sure we're going to provoke a lot more discussions as the session goes on today. Thank you.
Thank you very much.
Thank you, Christo. And we have to move the fourth lecture. The fourth lecturer is Charles D. Fraser from Austin, Texas. The lecture title is AVSD with Aortic Obstruction, Surgical Options. Could you start your lecture, Chuck?
Good morning, everyone, and thank the organizers for inviting me to this conference, which really looks to be an outstanding program. I know it's a lot of work to put together a conference like this, so thank you all. I'm sorry that we can't be together. It continues to be frustrating for all of us in this pandemic world that we can't meet in person too much, but certainly this series of conferences put on by the World University has been great, and again, I'm honored to provide a few comments. I must admit I've struggled with this subject, but here's some thoughts about what to do with arch obstruction in patients with atrioventricular septal defect. The issues include the fact that it's a relatively infrequent consideration. The ones that are most problematic, of course, are the ones that present early, the newborns, and often they can be very small, premature babies. And we always have to look for concomitant issues. What's going on in the left ventricular outflow tract? Often we're concerned that the left side of the heart is marginal, and I know this is going to be extensively discussed elsewhere in this conference, but patients may have a single papillary muscle, a persistent left superior vena cava. There may be important AV valve issues, maldistributed AV valve tissue. So the question for the surgeon and the management team is how hard to push on a two-ventricle reconstruction, which I know also is going to be discussed elsewhere. But without question, and also not unique to this problem, an inadequate or marginal arch repair not only exacerbates the risk acutely for the patient, but sets up for a lifetime of problems. We recently, just this last week, transplanted a young man who had several arch repairs elsewhere in association with single ventricle palliation, calcified homograft in the arch. It made for a very difficult transplant and probably also contributed to his early failure in a Fontan circulation. So we set the stage for the patient's life by a bad early repair. Our opinion in this subject and in, frankly, all complex congenital heart problems with arch abnormalities has been that an aggressive arch repair is warranted. Now, nowhere is the issue of ventriculo-arterial coupling more important than in a marginal AV septal defect arrangement. And we don't have time to review the elegant work that's been done in this subject, but suffice it to say that bad physiology, bad geometry translates into suboptimal long-term mitigation of the arch problem. And as many have said, if the arch doesn't look pretty after you're finished repairing it, it's probably not a good arch reconstruction. Now, this is just part of a brief management algorithm, or at least how I think about it. The situation usually is in the presence of a newborn with a complete AV septal defect. And the question is the arch adequate? Is there an isolated coarct? If so, maybe we can repair through the left chest. And in those settings, we do favor not placing a pulmonary band. Let's expand more on that in a minute. For other neonates where the arch is hypoplastic or even interrupted, we favor an all autologous repair with or without a pulmonary band from the front. And the challenging situation, of course, to be very well explored by others is the borderline left ventricle, what to do in addition to making sure the arch is adequately repaired. Do we set the patient up for a Norwood type palliation or an aggressive two-ventricle repair? I won't say much more about the various literature that's out there, but there's very little written about the management of the arch in the setting of complex atrioventricular septal defect patients. Thusly, I suppose, the reason this was added to this program. Our approach was started now almost more than 25 years ago when we started the program at Texas Children's, and then have expanded now here into Austin. And this elegant artwork really tells the story. We approach to a sternotomy, so a graft on the innominate artery, planned for antegrade cerebral perfusion, widely mobilized aortic arch. Obviously, this is done with the ductus divided. Liberally mobilize the descending thoracic aorta, reminding everyone that the thoracic aorta in babies is very, very elastic and can move a long way, which we all know. Mindful of the recurrent nerve, we favor mobilizing the aorta at least down to the first two sets of intercostals. And then a spatulated sliding type of anastomosis, which advances the normal caliber descending aorta to the distal ascending aorta proximal arch, thusly resulting in a more normal arch configuration. the surgeon and the management team has to spend a lot of time studying the arch preoperatively. And I'm certain that some of you would look at this and say, well, we might approach that through the left chest, but it's certainly justified to be liberal with the use of other forms of imaging, including computed tomography, to make sure that you're going to leave the patient with a completely unobstructed arch. And this was one that we would not approach through the left chest, we would approach through a sternotomy. This is just a brief movie of the standard approach that we use. This did happen to be a patient with an AV septal defect with a borderline aortic arch. And this is a 3.5 millimeter shunt that's sewn on before we open the pericardium. A 3.5 shunt will accommodate an 8 or a 10 French cannula. And then this patient had a persistent left superior vena cava, and we always cannulate that directly so that we don't have challenges with visualization in the intracardiac repair. And again, it's not an uncommon setting that in a patient with AV septal defect and an arch problem that there's a persistent left superior vena cava. Then under cardioplegic arrest, we proceed with the arch repair, again carefully mobilizing the descending aorta. And there's the isthmus. We ligate the isthmus and excise all the visible ductal and cortication tissue. Usually put the clamp on once to get a good purchase, then excise the abnormal tissue and move the clamp more distally on the aorta. And then under antegrade cerebral perfusion, which we're typically flowing between 50 and 60 cc's per kilo per minute at 18 degrees, and we use a near-infrared spectroscopy to adjudicate the flows and proceed with the arch repair. Usually takes about 20 minutes. Now, in this case, after the arch repair, we took the cross clamp off and we'll reperfuse the heart for a while and then proceed with the intracardiac reconstruction. And this is not this patient, but this is the type of configuration that we're looking for. We do know this is a very durable way to approach the arch. The freedom from reintervention is very favorable in our series that Dr. Mary, my colleague, published some years ago. We do, of course, as all do, know that there are patients that we can approach through the left chest, and if we adhere to the principles as previously mentioned and have the adequate substrate, this can also be a very durable type of arrangement. Of course, I won't belabor the point of coarctation repair for this audience other than to note that we don't favor placing a pulmonary band in this setting. I suppose it's fair to say never say never, never say always, but as a general rule, in patients with a coarctation that we repair to the left through the left chest, trying to get a good pulmonary band through that approach is pretty darn challenging. So we would typically leave the patient, and if the heart failure is too significant, go ahead and proceed with the intracardiac repair at a different operation. And there's a repaired cohort. So just a brief synopsis of my recommendations. We have to very carefully assess the arch to make the best management plan. This means precise measurement, echo, CT, MRI, not so much. We don't do that frequently in this setting. Definitely residual obstruction, marginal repair has consequences. We very much favor an all autologous tissue reconstruction. And then the decision about a simultaneous repair or staged repair really depends on the patient's age, size, the degree of AV valve regurgitation, and the surgeon's assessment of the adequacy of the left side, which can include the need to look inside the heart and make that decision game time in the operation. So again, thank you all for inviting me. Greetings from Austin, Texas. This is our new team at Dell Children's Hospital and the University of Texas, and we're busily working away here. I wish you all well, and again, thank you to the organizers for including me in this great conference.
Thanks very much for an excellent talk, Dr. Fraser. And congratulations on building such an amazing unit and team in such a short time in Austin. I think the main question from the audience is a fairly common theme amongst people trying to achieve an arch advancement. Do you have any tips on how to avoid, I guess, left pulmonary artery compression and left bronchial compression? And I know your results are truly excellent, so I'd be interested to know your technical tips.
Well, thank you, Yushay, and again, thank you everybody for having our program included in this. Really, the key is extensive mobilization. When I watch people use other methods for repairing the aortic arch, I note that they don't mobilize things quite as much as we do. So really, we have the entire ascending aorta, entire arch, extensive lengths of the brachiocephalic vessels, and then well down in the chest, as I said, down at least a couple of intercostal sets down the throat. And when you do that, you have so much laxity on the aorta. Now we're talking about newborns and small babies. That's not the case in older children, but in newborns, this really makes any issues with the trachea or the left main stem bronchus really, really rare. As Carlos published in our paper, the incidence of bronchial compression is extremely low. I think 1 or 2 patients out of hundreds. So it's all about the mobilization, really.
Yep. Thank you. And I guess the question that everyone always asks is, do you have specific either Z-scores or size criteria for defining adequacy of distal and proximal transverse arch to decide whether you do an arch repair from the side or one via stenotomy?
Yeah, it's the old, where this got derived from, I don't know, but it's the old Roger Me rule. It's the weight in kilograms plus 1, and it seems to always work. And, what I often tell our learners is that this is a situation where the surgeon has to sit with the echocardiographer, maybe the radiologist, and really make sure the surgeon is confident in the number. Someone asked, I think, on the question about the Z-score. I don't think most of us think in standard deviations. I think we think in absolute numbers. So again, that rule, simple as it is, really seems to always work. But it's incumbent on the surgeon not just to read the report, to look at it very, very carefully. And the echocardiographers can tell us a story, either a good story or not a good story. And we've got to make sure they're showing us the true geometry.
My sense is that configuration of the arch probably also guides us a little bit. Where you have a really elongated distal transverse arch that's small, that might push you more towards arch repair via stenotomy rather than from the side.
Yes, that's a very good point, Yushay. Completely agree with you.
Yeah. And then there are quite a few questions about when you do an arch repair and you do or don't band. Can you explain sort of your thought process for when you decide whether to band or do an early repair, and how early is early for you? Would you do a repair earlier than 4 weeks?
Yeah, those are always really tough decisions. We have a baby in the hospital right now that, frankly, I didn't want to have to operate on, but the AV valve regurgitation is so bad. And, I realize the data are conflicting about whether or not to try to repair a baby like that or place a band in the setting of bad AV valve regurgitation. But we have favored going ahead and when the babies have just hit the wall, going ahead and repairing. It just seems to be more predictable in our hands that way, but it's always a really tough decision.
I must admit, personally, over the years, we get earlier and earlier with our canal repairs, and we're doing less and less bands. And I think, like you've mentioned, if you can do a correct repair from the side and just get a few weeks, that seems to be a pretty good approach for those, I guess, more straightforward ones.
Very much so. I completely agree.
So we might move on, but I'm sure there'll be a few more questions as the sessions go on. So if you're happy to hang online, I'm sure there'll be a few more questions along.
You bet. Thank you so much.
Perfect. Thank you.
Thank you, Jack. So we have to move fifth lecture. The fifth lecturer is Ignacio Lugones from Buenos Aires, Argentina. The title is Unbalanced AVSD, Two-Ventricle versus One-Ventricle repair options. Could you please start your lecture, Ignacio?
Hi, my name is Ignacio Lugones. It is a pleasure to be here. I will talk about two-ventricle versus one-ventricle repair options in unbalanced atrioventricular septal defects. The term unbalanced in atrioventricular septal defect has been used to describe a lack of symmetry in size or distribution of blood flow between the pulmonary and systemic circulations. The anatomic imbalance reflects the asymmetry in size, while the physiologic imbalance reflects the asymmetry in blood flow distribution caused by the presence of intracardiac shunts or malalignment at the AV junction. So balance versus unbalance is not the key point here. The core challenge in this disease is to identify the most appropriate surgical approach for the patient. This can be easy on the ends of the spectrum. In the setting of moderate degree of imbalance in left dominant patients, the 1.5 ventricle repair strategy can be used. Many groups have also used an atrial fenestration, which in theory could offload the right ventricle, although this strategy has recently been associated to increased mortality and could be a marker for anatomic complexity and not an effective therapeutic strategy. But identifying the best surgical strategy in moderate imbalance in right dominant cases might be very difficult. That is because these patients walk on a thin line. On one side, they have higher mortality associated to univentricular palliation as compared to other entities, mostly due to severe AV valve regurgitation and other symptoms. On the other side, the left structures might not tolerate one-stage biventricular correction. These patients are then submitted to other repair strategies with no clear decision-making process, and therefore they have high mortality rates. To choose the most appropriate surgical approach, we have to evaluate the crux of the heart in the 4-chamber echocardiographic view. In it, we find two main elements, which are the AV valve, identified as a line trace between the left and right hinge points of the valve, and the VSD, represented by a line that is perpendicular to the AV valve plane and passes through the crest of the interventricular septum. If we add the left ventricular inflow and the right ventricular inflow, we have a triangle which is divided in two by the VSD segment. We can also identify the secondary annulus, which is defined as the narrowest diameter of color Doppler into the left ventricle. All these elements play a role in the surgical decision-making process. We will focus on three variables, which are the AV valve, which is evaluated by the modified AV valve index, the size of the VSD, which can be evaluated using the index VSD, and the mitral subvalvular apparatus, which is evaluated by the left ventricular inflow index. The modified AV valve index discriminates between balanced and imbalanced forms. It is defined as a ratio between the left AV valve area and the total AV valve area measured in subcostal view. Values above 0.6 imply left dominance. Values between 0.4 and 0.6 mean that the right and left components of the valve have similar size, and then the patient can be submitted to biventricular repair safely. Values below 0.4 reflect right dominance, and in this group, patients with values below 0.2 have no other choice than univentricular palliation because the left heart is too small. And there is a gray zone between 0.2 and 0.4 where patients are submitted to other repair strategies with high mortality rates due to inappropriate selection of the surgical approach. Due to the shape of the valve, the same relation between areas in the subcostal view is found between diameters in the 4 chambers view. The VSD segment divides the total AV valve diameter in left and right components. The modified AV valve index is then calculated as a ratio between the left component and the total AV valve diameters. But this index alone cannot predict outcomes of surgical strategy. There are other factors that influence this decision, and one of them, very important, is the size of the VSD. Cohn and co-workers found the direct relationship between the size of the VSD and mortality of one-stage biventricular repair. They conclude that in patients with moderate unbalance and a large VSD, univentricular repair should be considered. But how large is too large? Of course, there's not a unique measure. And the size of the VSD must be related to the size of the patient, or even better, to the size of a neighboring structure. This is why our group described the index VSD, which is defined as the ratio between the VSD height and the total AV valve diameter in 4 chambers view. We already stated that patients with a modified AV valve index below 0.2 should undergo univentricular palliation. Patients with modified AV valve index between 0.2 and 0.4 and an index VSD below 0.35 could be considered for one-stage biventricular repair because the VSD is considered small. This means that the left ventricle will be able to maintain the systemic circulation, as it was already doing that before the operation. On the other side, a large VSD in patients with moderate degree of imbalance reflected by a VSD above 0.4, such as that univentricular palliation may be a safer option. Because in this setting, the left ventricle is unloaded into the right ventricle and the pulmonary circulation, and its ability to manage the systemic circulation is at least uncertain. For patients with modified AV valve index between 0.2 and 0.4, and index VSDs between 0.35 and 0.5, alternative surgical approaches can be used. These patients have a VSD that is neither too large to force the univentricular approach, nor too small to allow single-stage biventricular repair. And in these cases, there are 3 main strategies that can be followed. When imbalance is mild, biventricular repair can be attempted, maybe leaving a small atrial fenestration. When imbalance is moderate, mostly at the expense of the AV valve component, the valve can be partitioned, placing the 2 patches more to the right and completing the biventricular repair. And when imbalance approaches to severe staged repair can be chosen in order to produce catch-up growth of the hypoplastic structures. Then as a first step, the ASD and the VSD are partially closed and the AV valve is partitioned a bit more to the right. The right ventricle is then kept at systemic pressures by a pulmonary artery valve and increases the systemic cardiac output through the residual VSD. Then, if the heart grows, the VSD and the ASD are closed and the pulmonary artery valve is then removed. Some of these patients have malformations of the AV valve and the subvalvular apparatus, such as parachute mitral valve, single papillary muscles, and accessory chordae. The presence of these malformations can cause obstruction at the true entrance of to the left ventricle. And Strass and colleagues described 10 years ago, more or less, the left ventricular inflow index, which is called the LVII, which is defined as a ratio between the secondary annulus and the left primary annulus in 4 chambers view. Patients with values below 0.55 have increased risk of mortality of biventricular repair and need to be surgically treated by splitting of a single papillary muscle or caudal thinning and fenestration, for example, and other strategies. The LVII is not a pure measure of the inflow. As you can see, it is much influenced by the size of the VSD, and this is why our group is working on a new variable called index secondary annulus, which might have the ability to assess the severity of the subvalvular obstruction in a pure fashion. It is calculated as the ratio between the secondary annulus and the total AV valve diameter. So to conclude, an unbalanced atrioventricular septal defect is a very complex entity. Do not focus on balance, focus on surgical strategy. In right dominant cases, this is easy when imbalance is severe or when the VSD is too large. Both cases go to univentricular palliation. There's no other choice. Do not panic in cases of moderate degrees of imbalance and follow this algorithm. Measure the mitral component and the total AV valve diameter. Then measure the size of the VSD. If it is small, you can try to achieve biventricular repair in 1 stage. And if not, you have other strategies you can think about. And never forget to evaluate the mitral subvalvular apparatus, because you might need to do something if there is obstruction at that level. Thank you very much.
Thank you, Dr. Lugones, for an excellent presentation about a very complex and challenging topic. We've got some questions coming through on the chat, but I thought one thing a little bit outside of your talk we could ask about is how you manage abnormalities, and particularly straddling of the AV valve apparatus when you're considering a biventricular repair for mild to moderate unbalance. And do you use different strategies depending on whether it's the right or left AV valve that's straddling?
Well, this is quite a big issue. When you have these patients, you have to work on the mainly on the mitral side. So these are the most complex patients. Many of them have severe obstruction of the left ventricular inflow. So many of them end up in the univentricular pathway. So we do not. We can work on the mitral subvalvular apparatus. We can split the muscles if there's fusion. We can work on the chordae. We can work on the valve. But these are very complex patients.
Yeah, and I think it's great that you and your group are continuing to look at really practical ways of assessing the heart to define how you approach these challenging patients. Do you use any 3D printing or modeling to help guide repair at all?
No, well, indeed, we think there's a big problem. There's a big difference that must be outlined here. These cases are not the same as those cases with left ventricle, borderline left ventricles. The presence of the VSD turns this in a real complex disease, because when you have a ventricle that is not unloaded through a VSD, you can analyze the size. You can think about how it might work after the correction using, for example, 3D imaging or volume, or measuring the volumes through MRI. But the point is that when you have this shunt, you cannot predict what will happen. So this entity must be completely separated from borderline left ventricle. So we do not use 3D reconstruction because the volume will not be the same before and after the correction. So we do not rely on this kind of techniques. We don't think that the size is measured by the volumetric size is measured by MRI, or other techniques are to trust.
And then the interesting question of the concept of ventricular growth in unbalanced AVSDs, do you think that is something that works? And I guess what's your strategy or sequence of operations to achieve it, and how do you assess it over time?
Yes, I think there is a wide, there are many opinions regarding that, because many groups say that any hypoplastic structure can grow, so that we need to force that. And I think it must be decided on each case basis. So I think that there are some techniques that really work, like dividing the valve, positioning the two patches to one side of the valve, trying to achieve a division of the valve that is relatively similar. You can work, of course, on the ASD, leaving small shunts to try to force growth. But this, against what could be thought, has demonstrated to increase mortality, as I said in the first part of the talk, when we talked about left dominance. So it is not clear, really, and we need to evaluate these patients a bit more. We need to have more patients. There are not too many, and we need large prospective studies to answer this question.
And have you and your group found any benefit to using 3D echo assessment to guide your decision making as well?
No, indeed. We rely mainly on the 2D, on the echo, on the 2D echo. We think that, as stated before, I think that volumes are not really too relevant here because you will change the physiology of the patient when you close the patch. So I think you need to evaluate the crux of the heart in as many portions of you as you can. I've just talked about the valve and the ventricular septal defect and the inlet, but of course there are other derangements that need to be addressed. Like Dr. Aiello said, there are malalignments of the atrial septum and the ventricular septum, so that also needs to be addressed. And we are also working on this topic too, because you can analyze which is the deviation that exists between the two septums. So if they're really malaligned, you will have double-outed atriums. So there is another triangle besides the one I depicted in those pictures. There is an atrial triangle. So we need to analyze that. I think it is just like a geometric puzzle, and we need to focus on the different parts of this geometric shape. So it is a really very complex issue. I found it really hard I struggle to make this talk because it's difficult to try to transmit just a clear pathway to how to proceed. So I think it is a lot more to discover on this topic.
I think you've managed to convey some very useful insights to the audience, and we're very grateful for your detailed presentation and explaining the geometric puzzle. It's definitely a 3D puzzle. Thank you very much. We might move on to the next talk.
Thank you.
Thank you, Ignacio. Great information. And we have to move the sixth lecture. So the sixth lecturer is Professor Sara Arrigoni from Groningen, Netherlands. The title is AVSD with Functionally Univentricular Heart, Long-Term Outcome. Could you start your presentation?
Dear colleagues, my name is Sara Arrigoni, and I'm a congenital cardiothoracic surgeon at the University Medical Center Groningen in the Netherlands. It is an honor for me to be invited as speaker by the World University for Pediatric and Congenital Heart Surgery. I have no disclosure. Patients treated with univentricular palliation for unbalanced atrioventricular septal defect represent about 10% of Fontan patients, and in the literature are associated with pure survival. 60% survival at 25 years and even 50% at 2 years has been reported. Up to 60% of the patients require a concomitant atrioventricular valve surgery in the course of their palliative treatment. Valve surgery has been reported to be associated with substantial mortality and a substantial rate of valve reoperation. Today, I shall present to you the results of our experience with single ventricle that is unbalanced. In fact, in our study, we analyzed the long-term outcome of 151 patients with single ventricle AVSD of all 7 units of our countries in this joint scientific cooperation of Belgian and Dutch pediatric cardiac units. 123 echocardiographic studies at follow-up could be collected. The endpoints of the study were the cumulative survival, incidence of Fontan completion, and freedom from atrioventricular valve reoperation. The long-term survival of our study was better than that previously reported, 68.5% at 20 years. However, 20-year survival of all Fontan categories remains remarkably higher, about 80%. We have also analyzed the postoperative mortality defined as in-hospital or 30 days mortality, which showed a trend of decrease in the last decade, although not significant. Moreover, our studies suggest that the presence of a genetic syndrome in association with single ventricle AVSD does not preclude an excellent outcome for Fontan palliation. In contrast with previous experiences, atrioventricular valve surgery did not decrease survival. On the other hand, multivariable analysis identified a severe atrioventricular valve regurgitation at follow-up as an independent risk factor for mortality. The analysis of echocardiographic studies at follow-up confirm that the degree of atrioventricular valve regurgitation at follow-up did affect survival. In fact, there was a significant difference in overall survival at 15 years follow-up, comparing patients with increasing degree of atrioventricular valve regurgitation, 89.2% by NOR or mild, 88.6% by moderate, compared to 58.3% by moderate severe or severe regurgitation. Cumulative incidence of Fontan completion was, in our study, better than the previously reported, 71% at 10 years compared to the range of 40-60. An atrioventricular valve surgery did not decrease the incidence of Fontan completion. At multivariable analysis, no independent risk factors for Fontan completions were found. 36 patients underwent an atrioventricular valve surgery. Among the surgical technique for repair, annuloplastic and edge-to-edge were the most frequently single technique performed. Our study confirmed that valve replacement in single ventricle does not have a favorable prognosis. 2 valve replacements were performed as first surgery, and both patients died at follow-up. 3 valve replacements were performed as reoperation, and 2 of the patients died during the hospitalization for valve replacement, which was performed together with TCPC. Freedom from atrioventricular valve reoperation at follow-up was not different from the range previously reported. About half of the patients require a reoperation at 15 years follow-up. As expected, all patients with moderate severe or severe regurgitation after the first valve surgery require a reoperation. There was a significant difference in freedom from atrioventricular valve reoperation at 15 years compared to the patient with NOR or mild regurgitation after the first valve surgery. However, a moderate severe or severe valve regurgitation after the first valve surgery did not decrease survival or incidence of Fontan completion. Freedom from atrioventricular valve reoperation at 15 years was significantly higher in patients who underwent valve surgery at time of Fontan completion, 87.5%, compared to patients who underwent valve surgery before Fontan completion, 31.5%. The favorable effect of unloading the ventricle on atrioventricular valve regurgitation may be a reason why the repair could be delayed until Fontan completion. However, the degree of atrioventricular valve regurgitation, deterioration of ventricular function, and patient clinical picture did not always allow to wait until Fontan completion. Anyway, there was no difference in survival between patients who underwent valve surgery before or at the time of Fontan completion. The main limitation of this study is its retrospective nature and its multi-center nature as far as prevalence of atrioventricular valve surgery concerns. In fact, there was a significant difference in prevalence of atrioventricular valve surgery among centers. This difference could be explained by the heterogeneous criteria for concomitant atrioventricular valve surgery and even for eligibility for fontan completion that could have even varied over the decades, influencing patient selections among the participating centers. Finally, we did not collect all echocardiographic studies of the patients in order to identify the first echocardiographic study where moderate or severe atrioventricular valve regurgitation appeared. Therefore, the degree of atrioventricular valve regurgitation could not be analyzed as time-dependent covariate. To conclude, in our study, the long-term survival and cumulative incidence of fontan completion of AVSD fontan patients are better than those previously reported. Concomitant atrioventricular valve surgery did not increase the mortality rate, nor decrease the incidence of fontan completion. Patients with moderate severe or severe atrioventricular valve regurgitation at follow-up had a worse survival, reflecting the need for adequate atrioventricular valve function. Our study allowed to conclude that in patients with single ventricle AVSD at the end of the fontan completion, atrioventricular valve function is a key issue, and an atrioventricular valve regurgitation which exceed a moderate degree should be repaired before or by finalizing the fontan circulation. Thank you for your attention.
Thanks, Dr. Arrigoni, for an excellent presentation. It's a fascinating paper that I'd recommend everyone read. It really has added a lot to the literature, and it's a really large group of very challenging patients. One question is, do you think there is therefore benefit to actually doing the atrioventricular valve repair and the fontan completion in the same operation? Because there are a lot of units who have the philosophy that maybe we should just repair the AV valve and then wait a year or two to do the fontan. Maybe it might be better to combine the two to unload the ventricle to actually aid the AV valve repair. Is that your sense of things?
Yes, thank you very much for the question. Actually, the majority of our patients underwent the concomitant atrioventricular valve surgery during the TCPs, so during the completion of fontan circulation. And I think that it makes sense. And what the patient were who underwent the atrioventricular valve surgery before fontan completion, especially at the time of the first palliation, the results were quite disappointing. So I think that it would be at least wait until the partial cardiopulmonary shunt operation. But the best, if we think also about the freedom from atrioventricular valve reoperation, is indeed the completion of the fontan circulation. So I agree.
Yeah, and they're really excellent results for repairs and then re-repairs. We've certainly struggled, and I'm sure many units have, with being able to get a durable long-term repair with some of these valves, particularly the RV dominant canals. Do you have a sense for why AV valve replacement is associated with such a poor outcome? Because I think most of the patients in the study didn't live very long after the AV valve was replaced. And should we accept maybe, moderate AV valve regurg rather than replacing it?
Yes, I think that the valve replacement does not have the favorable prognosis, and I think that the main problem is the deterioration of the ventricular function. And the 5 patients with valve replacement, 4 died at follow-up. And so I think that it could be hypothesized that it's better to accept for sure a moderate degree instead of perform a valve replacement, and the chance of pacemaker implantation could also further worsen the ventricular function, especially in an univentricular setting.
Yeah, it's a very challenging situation. And do you have any insight about the optimal repair strategies? Because these are also very difficult valves to deal with.
I have to say that the number of patients of the valve surgery group was too small, 36 patients. So we could not perform an analysis which could reach a statistical significance. And I think that if we could join the scientific cooperation of all countries that at this moment are participating at this meeting, maybe we could have enough patients to perform this further analysis. And because I think that if we want to improve the outcome of our patients, we need to analyze more the results of the past. And for this infrequent patient category, we need more collaboration. So maybe that's a challenge of this meeting and of the World University, to build a worldwide database so that we can share our experience and we can learn more.
Definitely. And I think there are some surgeons who clearly get very good outcomes, and to learn what they do, you know, the specifics of what they do, because the devil is in the detail. We could gain a lot from I think, collaborating across units. Another question was, did the pre-repair degree of regurgitation predict the need for re-repair?
We did not analyze that. Of course, the degree of atrioventricular valve regurgitation after the repair predict the chance of reoperation, because all patients with moderate, severe, and severe regurgitation require a reoperation. And I think that a few of the patients with non or mild regurgitation after the surgery require a reoperation.
Yeah. And is there a degree of AV valve regurgitation that would make you not go forward with a Fontan completion?
No, I think that if the regurgitation exceeds a moderate degree, I will go for a valve repair, but I will go on with the Fontan completion.
And the final very challenging question is, the Melbourne group actually published opposite findings. So they, with an outcome suggesting not to tolerate moderate AV valve regurgitation and to go ahead with the valve replacement. And do you have any suggestions for why the findings are divergent? Clearly, the group you've studied has very good successful outcomes, and it's really unique in that respect. And I wonder if the demographics of the group is different to the group in Australia that have been studied by Melbourne.
Of course, we analyzed all the patients that were considered suitable for surgery. So we did not analyze all newborn with an unbalanced AVSD and univentricular and possible univentricular palliation. So it's, of course, a patient selection. And on the other side, if we look at the number of patients who had the moderate severe or severe atrioventricular valve regurgitation at follow-up, they are just 10. So I think that the preservation, the good preservation of the ventricular function did improve the survival and anyway influence the outcome and the results of our patient cohort.
Yeah, great. Thank you very much. We might move on to the next presentation, but thank you for an excellent talk and all those excellent answers.
Thanks.
Thank you very much for the great information about the difficult cases. And we have to do the 7th lecture. So the lecturer is my co-chair, Professor David Overman from Minneapolis, Minnesota. The title is Late LVOTO in Partial and Complete AVSD, Surgical Technique and Outcomes. Could you start, please? your presentation.
Greetings. I'm Dr. David Overman at Children's Minnesota in Minneapolis. The title of this talk is Late LVOTO in Partial and Complete AVSD, Surgical Techniques and Outcomes. I have no disclosures. First of all, we must establish what we're talking about today. Left ventricular outflow tract obstruction, of course, encompasses many left-sided obstructive lesions, but today we will not be addressing coarctation or aortic arch hypoplasia, aortic valvar stenosis, or annular hypoplasia. Instead, we are focused on subvalvar aortic stenosis, and in particular, not extant or native anatomy LVOTO, such as is encountered occasionally at the time of primary repair, but instead only post-repair left ventricular outflow tract obstruction. And we will discuss both partial and complete forms of AVSD together. The incidence of post-repair LVOTO is 3 to 6% in the extant literature. Historically identified risk factors for LVOTO, such as Rastelli type A complete AVSD, partial AVSD, or the non-presence of trisomy 21, have largely been refuted in most recent literature. The time to reintervention for LVOTO after repair of AVSD is fairly long, 5 to 7 years in most reported series. And much attention has been paid to the impact of primary repair technique on late LVOTO. Recent literature, I think, firmly establishes the fact that the modified single patch repair is not associated with an increased risk of LVOTO. Why does LVOTO happen in AVSD? First, the aorta is unwedged from its position between the mitral and tricuspid apparatus, creating an elongated, abnormally shaped left ventricular outflow tract identified in the form of the gooseneck deformity, but in angiocardiography. The discrepant inlet and outlet septal lengths are further exacerbated by the presence of a septal scoop. In addition, there are multiple abnormalities of the papillary muscles, counterclockwise rotation. Many are closely spaced. Occasionally, the anterolateral papillary muscle will have a high insertion on the interventricular septum, which creates turbulence in the proximal left ventricular outflow tract. And finally, there are often accessory papillary muscles, or more importantly, accessory chordal apparatus, such as in this intraoperative photograph, wherein primary chordal support of the left AV valve necessarily is left to the left side of the ventricular septal patch. I want to call special attention to the anterolateral muscle bundle of the left ventricle, which is infrequently mentioned as a factor in left ventricular outflow tract obstruction in AVSD. The AMLV is present in 40% of the general population, but it is present in 100% of hearts affected with AVSD, as illustrated by Drawlin's note in 1991. The AMLV encroaches on the distal left ventricular outflow tract, and while it is not an etiologic factor for left ventricular outflow tract obstruction in and of itself, resection of the AMLV at the time of operation can have a dramatic impact on the geometry of the distal LVOT. The gold standard operation for left ventricular outflow tract obstruction in this setting, of course, is transaortic repair. This involves resection of the discrete fibromuscular shelf or ring, but also assiduous removal of any other fibrous depositions, particularly that involve the undersurface of the aortic cusps or the anterior leaflet of the mitral valve. Septal myectomy is important in the setting of a hypertrophic septum, and division of any secondary or tertiary cords that cross the LVOT is also important. As mentioned, resection of the AMLV can have a dramatic impact on the resulting geometry of the distal left ventricular outflow tract. Dr. Van Arsdale and colleagues at the Hospital for Sick Children over 25 years ago surveyed their experience with this entity. and concluded that the rate of reoperation was high in children treated by fibromyectomy alone. Thus, a successful operation addresses all present and future anatomic contributors to left ventricular outflow tract obstruction. But LVOTO will recur, and in the setting of recurrence or complex forms of LVOTO, the modified Conal procedure is an excellent surgical strategy. It is particularly well suited to tunnel-like obstruction, and it is effective in the presence of what are otherwise immutable factors in left ventricular outflow tract obstruction, such as primary chordal apparatus that cannot be resected. In this illustration from Jonas's manuscript in Op Techniques, through a transverse infundibulotomy, an interventricular septotomy is made and enlarged to a ventricular septal defect, which is then closed with a patch, thereby enlarging the circumference of the LVOT. Importantly, though, in this schematic from Calderon's manuscript in the Annals of Thoracic Surgery, leftward resection of the interventricular septal muscle is also important and will have a dramatic impact on the resulting capacity of the left ventricular outflow tract in the setting of a modified Cono, and this should accompany any modified Cono operation. Leaflet resuspension is occasionally reported as an adjunct maneuver in patients with atrioventricular septal defect and LVOTO. Usually at the time of primary repair, this technique involves detachment of the superior bridging leaflet, enlarging a small or moderate VSD, or even in the setting of partial AVSD, resuspending the leaflets to the top of the VSD patch. This operation definitely has an impact on the geometry of the left ventricular outflow tract, but I would say it is relatively incremental to the more radical modified Cono procedure. Apical aortic conduits are mentioned only for completeness sake and historical interest only. Surgery for LVOTO is carried off with very low operative mortality rates. It should be noted, though, that Kaplan-Meier analyses of survivors of LVOTO surgery display survival rates of only 85 to 90% at 15 years. Recurrence of LVOTO happens in roughly 15% of patients. And acquired postoperative complete heart block complicates the course of 5 to 15% of patients at primary or redo operations for LVOTO, respectively. In large cohorts of adults with subaortic stenosis, aortic insufficiency is found in 80 to 100% of patients. Fortunately, a minority will experience progression of the AI to a hemodynamically significant lesion. However, an incidence of 20% is certainly worth noting. In conclusion, then, left ventricular outflow tract obstruction occurs in roughly 5% of patients after primary repair of AVSD. Its anatomic etiology is multifactorial. The anterolateral muscle bundle of the left ventricle is a constant feature of the left ventricular outflow tract in AVSD, and an effective operation addresses all anatomic contributors to left ventricular outflow tract obstruction. Transaortic resection is suitable for the overwhelming majority of patients and is an appropriate first-line strategy. However, recurrence can be expected in upwards of 15% of patients. In recurrent LVOTO, the modified Cono procedure is a very effective second-line approach. Leaflet resuspension techniques may be useful in special circumstances. Thank you for your attention. I'm happy to take your questions at doverman@chc-pa.org or on WhatsApp or now. Thank you.
Thanks, David, for that detailed presentation, and apologies to the audience. I think we skipped some editing at the beginning to remove the helicopter noise. I think that the main question that is on most people's mind is, do you think it would be reasonable to go straight for modified Cono as the first left ventricular outflow tract operation? I certainly must say my practice really is just to go and do that as the first operation on the LV outflow to mitigate the risk of recurrence. As I'm interested to know what your thoughts are.
I guess my feeling, Yishe, about that would be that, again, I think that the majority of patients can have a very effective transaortic operation. It does need to be detailed, does need to be thorough, assiduous, but I think the majority of patients, so if you're looking at a recurrence rate of 15%, well, that means 85% of the patients get away with a primary operation, and that historically, of course, has been a transaortic repair. So I guess my own feeling, it is a very effective operation. I think it can be carried off very safely. I just think it's probably a bigger operation than is necessary in most patients. That'd be my view of it.
Excellent. Well, thanks very much for a great talk. And we just in the interest of time, we might keep moving forward and save some more questions for the end.
Okay, thank you very much, David. So we have moved last two lecture. The eighth lecturer is Professor Graham van Astel from Los Angeles, USA. The lecture title is AVSD, Surgical Repair Techniques for Late AV Valve Regurgitation.
Good morning. Repairing the left AV valve late following a repair of an atrioventricular septal defect. The first thing about this topic I would say is you don't want to be an expert in it. Having said that, the way to avoid being an expert in it is to get the repair right in the first place. So if you get the repair right or quite good, your chances of reoperation out to 15 years are really only about 10 to 15%. If you don't get it right, then obviously there's a high likelihood that you will need to reoperate. So good repairs, leave them alone. Those that have moderate regurgitation or mild to moderate gradients, revise them at the time if you can, if the heart will tolerate it, and if there's something you can do to make it better, because that will be good for the patient in the long term. So having set the stage that way, what's the incidence of reoperation? This is a nice series out of Sweden that's just published. For those patients greater than 3 months of age, and that's 250 patients, you can see out to 15 to 20 years, the freedom from reoperation is about 10%. I'm sorry, the freedom from reoperation is about 90%. For those less than 3 months of age, it's not quite as good, but still reasonably favorable. But you can see those reoperations in those less than 3 months of age tend to be much earlier. So that would be consistent with what we would naturally think as well. So I would say there are three things that you most commonly see or need to use in repairing atrioventricular septal defects late when there's regurgitation. The most common cause of leakage is splaying of the cleft. So here's a cleft closure in a patient at the primary operation, and you can see there's often a little bit of a V shape at the very end that if you fully close, the leaflet curls under and you get regurgitation. If you don't close enough, you have a little bit of a V that leaves a spot for regurgitation at the time. And part of what you do initially is find the best option for that particular patient and leave it in that condition. Well, you might have a little bit of central regurgitation, and that sometimes turns into more regurgitation and annular dilation. And when you come back, it may be that you just narrow the annulus a little bit and close the cleft a little bit further, and you get a very nice repair. That's not uncommon to see in these reoperations. So here's such a case. Here you can see this patient has no stenosis. It has nice thin leaflets that are broadly pliable. You can see that there is some regurgitation that is likely related to the cleft. And most likely with this annulus size, no stenosis, you'll be able to just narrow that cleft a little bit, perhaps do some local commissuroplasty sutures without a full annuloplasty, and get a nice repair with very little regurgitation that would be successful going forwards. When the situation's a little more tough and you have insufficient leaflet, then you have two options. One is to augment the leaflet at its base. So here's an example of taking the leaflet down from commissure to commissure and adding in a patch. This results in a gradient, so you want to be careful about who you do this on. You need to have an adequate orifice for this to happen. Or, as Christian Brizard has described, augment the cleft itself, where that V is, and do that with a patch and add in some chordae. And this can be an effective way of managing the leading edge. And here's such an example that he shows. And of course, we know about this technique when you have good leaflet mobility, but have failure of coaptation. Carpentier described this way back as a good strategy for dealing with these patients. So here's such an example in a patient with a cleft augmentation. Initially, the chordal length wasn't quite right, and you go back and adjust the chordal length and you get a better repair strategy. So this avoids tension if you have thin leaflets, and it can also be a good strategy if you're worried about the orifice size. Of course, there are other strategies that we have that have long been known: chordal transfer for prolapse, or using artificial Gore-Tex chordae. These chordae obviously don't grow, but it's been shown that they're durable and that the leaflets and the papillary muscles seem to adjust around them. And these chordaes can be a good means of dealing with prolapse regurgitation. Of course, sometimes, despite doing what we intend to do, these edge-to-edge repairs become necessary, such as an Alfieri stitch, which can close the gap and sometimes get you out of trouble, albeit one has to worry about how much stenosis you're creating. And I think most of us see this as a type of repair that we use as a last resort as opposed to a primary repair. Nevertheless, it can be successful and may actually keep you from having to replace a valve for a number of years. And of course, then we get those patients who have parachute left AV valves. And these valves can be split in a horizontal direction, which then gives you two good orifice, one medial and one laterally. Pedro Del Nido talks about needing to split commissures sometimes and thin the leaflets. And these, while this is written for primary mitral stenosis, it can potentially be of value in left AV valves. And here he describes how you can also augment the posterior leaflet when there's leaflet restriction. In this case, it would be a mural leaflet. Here's a situation where a patient had a couple repairs early. You can see over here, you have very thickened leaflets and leaflet deficiency and an enlarged annulus. Despite that, the gradient is about 16. So to manage this patient, one would anticipate that a repair may not be possible, but you may be able to split the commissures and do some type of leaflet augmentation that could result in a successful repair, but you'll have to ask me in a few months whether or not that's successful. Of course, in older patients, if your repairs are not successful, we move right on to mechanical valve replacement. The durability of biologics in young children is still not very successful. However, in the very small children, this technique of implanting a melody valve described by Ram Imani has been successful. And these valves seems to be more durable. I suspect it's because the leaflets are much thinner than a typical biologic valve. In this situation, you can cut back on the structure of the valve housing a little bit, which then allows you space for an outflow tract, and you implant about half of it in the atrium and half of it in the ventricle. If you don't have a Melody valve available, there are these techniques of supraannular implantation, either directly supraannular or with a tilt, anterior or posterior tilt. Here's a technique of doing it supraannular, implanting the valve within a Gore-Tex tube, and then attaching the Gore-Tex tube in the usual way with flegeted sutures to the annulus, and it leaves room for the valve to successfully move. And it allows you to get a valve in a situation where you would not perhaps be able to place it intraannular. So here's a look at overall survival for valve repair from the group in Leiden. Very high survival for repair, not as high for replacement. And then if you look at the reoperation rate, freedom from reoperation was about 70% out at 5 years. And obviously, if you reoperated at 5 years of age and you got another 5 years of age, that can be very important for the quality of life of the child or even for the survival of the child. So I would say the most important thing is do everything right the first time. That's how you prevent the need for reoperation. You have 3 primary tools for regurgitation: further cleft closure, cleft augmentation, or leaflet augmentation, either anterior or mural. And then for those with mixed lesions or stenosis, you can split the papillary muscles or split the commissures and potentially add in leaflet augmentation associated with it. But when you fail, obviously replacement is preferably mechanical if they're old enough to manage the anticoagulation, or in those younger patients, a Melody valve is has been really beneficial. Thank you.
Thanks, Dr. Van Astel, for another excellent talk. I think you've covered the topic beautifully across both webinars. Important question, I guess, at the time of first repair is, I think we all understand it's probably better to have a little bit of stenosis to get really good valve competence. Do you have a particular mean or peak gradient you'd accept beyond which you wouldn't really go to get adequate valvular competence?
Well, I think an excellent repair is a mean of less than 3 or 4. If you start getting above 6 or 7, then I start worrying about the long-term consequences. So the real questions, I think, at the beginning when you first operate are, did you spend enough time on the first cross clamp? So one of the things about atrioventricular septal defects that I think is important to understand is these are fantastic hearts. They tolerate cross clamps. So good myocardial protection, they're going to tolerate a long cross clamp, and you should really spend a lot of time tweaking, adjusting, testing, really working on getting the best you can for that particular valve. So if you've done that, when you come off bypass and you look at your echo, then you ask the question, is it satisfactory or not? And if it is, great. If it's not, then you have to ask the question, can I actually do something different to make it better? And if the answer is yes, and you have good myocardial function and it's going to tolerate another cross clamp, then you should go back on and modify it. And I would say you should even modify it. Let's say you have mild plus regurgitation and no stenosis, and you knew if you adjusted the cleft a little bit, you're going to have mild or no regurgitation and raise the gradient to 3 or 4. Then you should go back on and modify it, because you're talking about how do you make a quality of life for this child for the duration. So if you get up to gradients of 6 or 7, then you have to start asking the other question is there no regurgitation, and do you need to allow a little bit of regurgitation so that you have a gradient of 4 or 5? And these are a little bit of judgment calls, but certainly there should not be a judgment call if you have good myocardial function and you have moderate regurgitation or moderate to severe regurgitation. Should you go back on and try to modify it? And the answer is yes, if you can do something more. If you've done everything you can do, then it's about trying to get this child to survive without replacement using medical therapy.
Yeah. And do you have any tips about getting the VSD patch height just right for the double patch repairs? Because that's obviously a significant impact for getting that good AV valve coaptation.
Well, I would say that the mistake you don't want to make is make it too high. That you get it more into trouble if you make too tall a patch. We know that you can have no patch and be successful. So the idea of using the patches of a bit of an annuloplasty has been advocated. Maybe make it 10% smaller than what it should be. And then it acts as a bit of an annular reduction type of situation, which can make it so that you have better competency.
And just developing that theme of annuloplasty in the primary repair and also reoperations, do you have any parameters that you use to determine how tight you make your annuloplasty, how many, presuming they're like compression annuloplasties, how many sutures you'd put in, any guides in terms of technical detail?
You know, I suppose everybody has their nuances in how they do surgery. And I guess what I would say is almost always I put one compression annuloplasty suture in between the mural leaflet and the superior bridging leaflet. And that often makes substantial difference in the amount of regurgitation that you get. If I'm not happy with that, then I'll add in a second one between the inferior bridging leaflet and the mural. And occasionally it's a trial and error situation, and you might add in one or two more, but ultimately you're looking at how do we keep from having stenosis, and kind of a rule of thumb is 1 or 2, maybe 2 millimeters smaller than what the Z value of 0 would be, and you could be okay. And that's for a typical baby who'd be maybe 4 to 6 months of age at time of repair.
Excellent. Thank you very much for sharing all of your insights. And we might move on to the last talk.
Yeah. Thank you, everyone, to Graham. And we have to move the last talk. So last lecture is made by Professor Gaurav Kumar from New Delhi, India. The presentation title is AVSD, Rate Presentation and Pulmonary Hypertension.
Good evening. My talk today is on late presentation and pulmonary hypertension in atrioventricular septal defect. I thank the organizers for inviting me to this talk. My name is Gaurav Kumar. I am from New Delhi. I have no disclosures. Well, a large percentage of the congenital heart disease burden comes from the developing world. In fact, 4 out of 5 kids with congenital heart disease come from the poorer countries, where delayed presentation is a rule rather than a rarity. But if you look at the evidence and data available, there's hardly any. So most of this talk is from personal experience and from experience of colleagues from this part of the world. Well, it is a real problem in the developing world because of widespread poverty, ignorance in both patients and primary care physicians as to what is the correct timing of surgery in these patients, lack of awareness that it's a completely correctable condition and some patients just condemn their children to die. And worst of all, the lack of primary medical care facilities. Well, we have heard over the last webinar in this that the aim of surgery is a complete repair of the defect with septation at the atrial and ventricular level, with a competent right and left atrioventricular valve and successful management of pulmonary arterial hypertension in the short and long term. So our preference is to operate a baby at 3 to 4 months of age in AV septal defect if the baby is gaining adequate weight and the symptoms are controlled on medication. But we still prefer to do a pulmonary artery band in a very low birth weight baby who's very symptomatic or has recent pneumonia or infection or has uncontrolled congestive cardiac failure or severe malnourishment, because we feel that banding these babies gives them a better chance to come up for a complete repair at a later time. We prefer to operate the partial AV canal defects as early as possible after 1 year of age. So considering these preferences, we define delayed presentation as a complete AV canal beyond the ideal operable age. So a complete AV canal beyond 4 to 5 months of age falls in the subset of a delayed presentation. A partial AV canal at 3 to 4 years of age, and one of these subsets of delayed presentation is a complete AV canal who has been banded in early infancy and comes up for a complete repair at a later date, because this is definitely an isolated different subset. Well, once these babies reach this stage, it is a problem for the cardiac care team. There are multiple dilemmas to assess the reversibility properly, to evaluate the operability correctly, to achieve a satisfactory repair, and manage the pulmonary vascular reactivity in the post-operative period, which can be life-threatening, and also manage long-term pulmonary vascular disease. So all in all, the most important part of management of these children is the correct assessment of operability, which is a combination of a detailed clinical examination, a detailed echocardiographic study, and occasionally a hemodynamic study. So there are two subsets. One is a child who has no tachypnea, has a peripheral cyanosis, clubbing, auscultation shows no features of left ventricular volume overload. This baby is definitely inoperable. The difficult decision-making comes in the intermediate group, where the baby comes to you with a saturation ranging between 88 to 93% on room air, some amount of tachypnea, X-rays equivocal. The echocardiography shows a bidirectional shunting at the ventricular level with variable degree of left and right atrioventricular valve leak. And you find this kind of a picture on echocardiography with a rainbow at the ventricular level. It shows a reasonable amount of pulmonary venous return, but more often than not, these patients require a cath study. Well, echocardiography gives you definitely inoperable patients in which there's a large RV with a hugely dilated PA and a low volume left ventricle with low pulmonary venous return. But a volume loaded RV and LV with a torrential return despite a bidirectional VSD flow might still be operable. So our cardiac cath study criteria are fairly fixed, which says a raised and fixed pulmonary vascular resistance of more than 6 Foots unit after 100% oxygen administration, which does not fall below 6, is a definite inoperable patient, although some of my colleagues whom I spoke to take up to 8 Woods unit as operability. A PVR-ISVI ratio of more than 0.3 is a high-risk patient, and more than 0.5 to 0.6 falls in the inoperable range. Some of my colleagues follow a left ventricular injection which fills the aorta and not the PA as a sign of inoperability. The surgical technique is standard, although the anesthesia requires deep induction and a deeply sedated baby from the time of induction till the time he is shifted to the intensive care. We do not use any PA or left atrial lines. My personal preference is a modified single patch or the Australian technique for most repair, unless the VSD is deeply scooped out and more than 1 centimeter, where I use a 2-patch technique. I have never used a single patch technique for my patients. The post-operative management in one of my former units where I operated for a very long time was fairly aggressive about early extubations. So there we used to, and they still do, use an epidural catheter to infuse bupivacaine for a neuroaxial blockage, which causes pulmonary and systemic vasodilatation, helping both the right ventricle and the left ventricle. IV sildenafil is used in a loading dose at removal of cross clamp, followed by a continuous infusion. Nitric oxide is on standby, but it's seldom required. We fast-tracked all babies to early extubation, followed by a high-flow nasal cannula at 2 liters per kg per minute. Our experience between January 2012 and September 19 with 49 complete canals which we operated, of whom 11 were delayed presenters and 7 of those 11 were Down syndrome. With a median age of 14 months, a bypass time of 93 minutes and a cross-clamp time of 59 minutes, all patients were fast-tracked. One patient was reintubated because of poor respiratory effort. We attempted multiple delayed extubations. He landed up with sepsis and low cardiac output, and our only early mortality. We had one late mortality who developed pneumonia at home. That was a Down syndrome baby. 9 patients are still on follow-up. 1 patient has a moderate left AV valve regurgitation and a moderate left residual pulmonary arterial hypertension. In my present unit, we are fairly conservative with our post-operative management. We electively ventilate our babies with deep sedation using morphine and midazolam. We use dobutamine, milrinone, and levosimendan for pulmonary vasodilatation. We employ a gradual weaning, and we stop weaning if the cardiac output drops or pulmonary artery pressure increases, as evident by echocardiographic findings. Oral sildenafil is used if required, and post-extubation, we electively employ nasal CPAP to maintain oxygenation. My experience with this protocol between November 2019 and July 21, I operated on 4 late presenters with a median age of 25 months. A similar bypass and clamp time with no mortality. 1 patient is on early follow-up with moderate left AVVR. Well, the second subset in the delayed presenter is the post-PA band group. Will employ the standard repair in which we remove the PA band, use a pericardial patch to reconstruct the main pulmonary artery, avoiding a pulmonary regurgitation. We resect the muscle bundles and the RV which may have developed. The right ventricular pressure in these babies is frequently high, so we try and avoid a right AVVR. And finally, I would like to speak about the partial AV canal, who are late presenters, which can be a difficult entity not to be taken lightly, because they often present in adulthood or late teens with frequently long-standing mitral regurgitations through the cleft, deformed leaflets, both the left and right in annular dilatations. So in these cases, valve repairs may not come out satisfactory, and these patients definitely have a higher incidence of primary and secondary valve replacement. Thank you for your patient hearing.
Thanks very much, Dr. Kumar, for an excellent presentation about a very challenging topic. I think, as you emphasized, the 2 key issues for the late presenters are clearly making that decision to operate, and you've outlined that really nicely, and then the details of the post-operative care, which is so essential because that period of time is so challenging because of the pulmonary hypertension and the sudden pulmonary hypertensive crises these babies can experience. So they're very challenging subsets, so excellent results. I'm interested to know, do you have some specific details about your approach to annuloplasties and the late presenting partial AVSDs? So I think it would be not uncommon in India for adults to present with an undiagnosed partial AVSD with significant AV valve regurgitation. How do you address the left AV valve in those contexts?
Well, Yisha, yeah, about 50% of our patients which we operate present in their late teens and early adulthood. I mean, these patients generally have a grossly dilated biventricular presentation. The leaflets are not so good, and sometimes they do not have adequate leaflets to really get a proper repair, and you don't want to leave a leak in this patient. So a posterior annuloplasty with a Dacron half ring is my preferred choice if I manage to get an anterior leaflet which after repair of the cleft is large enough to sort of give a good coaptation surface on both the leaflets. 2 sutures on the annuloplasty on the commissures, and a posterior partial annuloplasty with a partially cut Dacron ring is what I prefer to do in these patients.
Excellent. You've clearly got a lot of experience, so thank you for your insight. So there's one more question here. The early presentation of pulmonary hypertension and AVSD is usually due to the combination of high pulmonary flow and venous congestion from the left AV valve regurgitation. That's, I guess, partly driven by the cardiac dilatation. Do you agree with that? And do you have any other comments? And I guess that the other significant issue as Downs versus non-Downs, and how those kids present as well?
Yes, so see, it's when they're present early with severe pulmonary hypertension, it's really a flow situation. It's not really a fixed pulmonary hypertension which is there, but the moment they start crossing 6, 7, 8, 9 months of age, it becomes, because of the quantum of increased increased pulmonary blood flow, they very rapidly start developing a fixed kind of pulmonary vascular bed. In Down syndrome or any other syndromic babies, we generally tend to find that in comparison to non-Downs babies, they have an earlier onset of fixed pulmonary vasculature, and a lot of them by 6, 7, 8, or 9 months have become inoperable in our experience. We cannot safely get away with the surgery for these patients. So yes, a flow-related pulmonary hypertension in an early presenter is very different from a fixed pulmonary hypertension of a late presenter. Invariably, all echocardiography in even an early presenter would show severe pulmonary arterial hypertension. But if you repair them at 3 months of age, by the time you're coming off bypass, the PA pressures have fallen down to normal if you have got a good repair, which does not happen in case of these late presenters who are at 1 year or 1.5 years. And occasionally, even when we come off bypass, they have PA pressures to the extent of 50 to 70% of systemic. And we have to employ various methodologies to keep these PA pressures down, as I told in the post-op period. So these two subsets are very different, and severe PH in an early presenter and a severe PH in a late presenter is definitely two different entities.
Yeah. Excellent. Thank you very much. I might hand over to Sabu for the concluding remarks, but once again, thank you for your presentation and your valuable insights.
Thank you.
Okay. Thank you very much, co-chair, Dr. David and Dr. Ishai. So we had a very good 2.5-hour session, and I would like to make concluding remarks. I want to thank all of our esteemed colleagues for sharing their expertise with us today, and to all of you for joining us. This has been the 11th in our series of monthly webinars in congenital heart surgery for the World University. This concludes the inaugural year of curriculum webinars. We will be starting the 2021 or 22 program year with hypoplastic left heart syndrome, the basic one, on October 30th. By the way, if you are a member of the World Society, don't forget to join us for the annual members meeting on September 18th at 9:00 a.m. More information will be sent soon. Before ending, I want to remind everyone that this webinar was recorded and will be available on the World University website. Anyway, thank you and have a great weekend. Goodbye all.
Thanks, everybody.